So someone asked, if you're a neurologist, what are you looking for on the fundus examination, and how can that help us diagnose a brain tumor? So if you're a neurologist, you pretty much don't have the indirect ophthalmoscope. You only have the direct ophthalmoscope. The direct ophthalmoscope is really great for looking at monocular clues only. So when we're using the indirect, we have a bigger field of view, but it gives us three-dimensional stereoscopic vision because we're using two eyes. It's a binocular device. The direct ophthalmoscope is not that different from the instrument that Helmholtz invented in the 1800s. However, the direct ophthalmoscope is good for one thing for a neurologist, which is looking for papilledema. And that's really the main thing. You're not trying to diagnose some diabetic retinopathy or look for hemorrhages in the way periphery or a retinal detachment. You really are only using the direct to look at the nerve. And there's two ways that you can look and find the brain tumor. The first is papilledema, which is the sign of increase in intracranial pressure, and the second is optic atrophy. And the amazing thing about the direct ophthalmoscope is you can buy ophthalmoscopes now that give you a wider view, and you don't have to play with the clicking of the little lens and stuff. You just stick it on the person's eye, and it's got like a little suction cup, and it just shows you the fundus. So the modern panoptic type devices can look into the fundus without having to focus and click all those dials. And so for a neurologist, really you're only asking yourself one question: is the nerve normal or not? And if it's abnormal, is it swollen or pale? And that's how you detect a brain tumor as a neurologist with the direct ophthalmoscope.